conference. You are currently the only person in this conference. You are currently the only person in this conference. You are currently the only person in this conference.
Okay, I'm just going to get started to ensure that there is a review in its entirety for everybody to go back to on the recording. So I'm just going to go over chapters 17 to 20. These are ones that are probably going to be going over in your clinicals throughout this week. So this is just some supplemental material for that. So chapter 17, quality of life for children living with chronic or complex diseases. Trends in the treatment of children with chronic illness or disability focus on developmental age, the child's strengths and uniqueness, family-centered care, normalization, early discharge, home care, mainstreaming, and early intervention. Using a developmental approach rather than one based on chronological age when caring for children with special health care needs helps the nurse determine the children's current status and understand their response to the chronic illness or disability. Developmental changes in the child continue despite the added stress of coping with a chronic illness. In response to the child with chronic illness or disability, parents may be affected by feelings of inadequacy and failure, excessive demands on their time, energy, and financial resources, and strain on the marital relationship. Family reactions to disability and chronic illness are manifested in the following stages: shock and denial, adjustment, reintegration, and acknowledgement. The child's reaction to illness or disability depends on the child's developmental level, coping mechanisms, reactions of others, and the illness itself. A child's conceptual understanding of his or her own illness is based not only on age and developmental level, but also on the duration and type of experience accumulated with the disease. When assessing the family's adjustment to the child's chronic illness, disability, or death, the following should be noted: the availability of the support system, the family's perception of the event, their coping mechanisms, their concurrent stressors, and their response to the child. Supporting the child involves encouraging self-expression, alleviating feelings of being different, and strengthening the child's self-image. Alleviating the child's feeling of being different and normalizing his or her life as much as possible is one of the most important interventions nurses can provide. Children who are concerned that their condition detracts from their physical attractiveness need attention focused on the normal aspects of appearance and capabilities. Health professionals help strengthen and consolidate the self-image by emphasizing the normal while allowing children to express anger, isolation, fear of rejection, feelings of sadness, and loneliness. Promoting the family's adaptation to the day-to-day management of the child's condition involves education about the child's condition, general health care and developmental needs, and about realistic goal setting. Emotional support and assessment of the family also play a pivotal role in adaptation. Encourage families to articulate their goals and approaches to managing their child's condition, which provides vital information on how to intervene more thoughtfully with families based on their treatment approach. The death of a patient is one of the most stressful aspects of nursing. Nurses experience reactions to the death of a patient that are very similar to the responses of family members, including denial, anger, depression, guilt, and ambivalent feelings. Okay, so I'm going to move into chapter 18, impact of cognitive or sensory impairment on the child and family. So cognitive impairment, or CI, is a general term that encompasses any type of intellectual disability. In this chapter, the term is used synonymously with intellectual disability, cognitive impairment. Intellectual disability, defined by the American Association on Intellectual and Developmental Disabilities in Children, consists of three components: 1, intellectual functioning; 2, functional strengths and weaknesses; and 3, age younger than 18 years at the time of diagnosis. The underlying assumption is that when appropriate supports are given over a prolonged period, the ability of the person with CI to function each day will generally improve. Causes of severe CI are primarily genetic, biochemical, and infectious. Mild impairment is associated primarily with familial, social, and environmental causes, whereas severe disability is more likely to be associated with specific syndromes. Education of children with intellectual disability emphasizes sensory and verbal discrimination, improvement of short-term memory, motivation, and technological support. Early intervention programs have been widely promoted for children with developmental disabilities, and there is considerable evidence that these programs are valuable for children with CI. Early intervention program is a systemic program of therapy, exercises, and activities designed to address developmental delays in disabled children to help achieve their full potentials. Promoting optimal development involves family guidance regarding play, communication, discipline, socialization, and sexuality. It requires appropriate guidance for establishing acceptable social behavior and personal feelings of self-esteem, worth, and security. Prevention of intellectual disability focuses on support for the preterm neonate and other high-risk newborns, rubella immunization, genetic counseling, and maternal education regarding the risks of chemical use, such as alcohol ingestion, and the importance of adequate nutrition. Down syndrome, a chromosomal abnormality, is characterized by mild to moderate CI, physical characteristics, slow language development, congenital anomalies, sensory problems, and diminished growth and sexual development. Although the cause is unclear, the cytogenetics of this disorder is established. Apparently, approximately 95% of all cases of Down syndrome are attributed to extra chromosome 21, group G, thus the name non-familial trisomy 21. Although children with trisomy 21 are born to parents of all ages, there's a statistically greater risk in older women, particularly those over 35 years of age. Hearing impairment is a general term indicating disability that may range in severity from mild to profound and include the subsets of deaf and hard of hearing. Hearing disorders may be classified according to the location of the defect as conductive sensorineural, mixed conductive sensorineural, and central auditory and perception. Rehabilitation for hearing loss involves parent education and support, hearing aids, lip reading, sign language, speech therapy, and promotion of socialization. Prevention of hearing loss includes treatment of infection, universal newborn screening, child auditory testing, immunization, pregnancy and genetic counseling, and reduction of noise pollution. Visual impairment is a general term that refers to visual loss that cannot be corrected with regular prescription lenses. Common visual impairments in childhood include refractive errors, amblyopia, strabismus, cataracts, glaucoma, trauma, and infections. Prevention of visual impairment focuses on prenatal screening, prenatal and perinatal care, periodic vision screening, immunization, and safety counseling. Nursing goals in visual rehabilitation include helping the family and child adjust to the child's visual impairment, promoting parent-child attachment, fostering optimal development and independence, providing for play and socialization, and informing families about educational facilities. For the child undergoing ocular surgery, nursing care is aimed at reassuring the child and family throughout treatment, orienting the child to the surroundings, providing a safe environment, and encouraging independence. The most common cause of communication impairment is CI, followed by hearing impairment. Other causes include 1, central nervous system dysfunction or injury, such as learning disabilities or traumatic brain injury, 2, autism, 3, childhood schizophrenia, 4, organic problems such as cerebral palsy, cleft palate, vocal cord injury, and paralysis of foreshortening of the soft palate and uvula, and 5, some genetic disorders such as Creutzfeldt syndrome and Gilles-de-Tourette syndrome. In some instances, such as in stuttering, the cause is unknown or speculative. Autism spectrum disorders, or ASD, are complex neurodevelopmental disorders of the brain function accompanied by a broad range of severity of intellectual and behavioral deficits. ASD is now recognized as a genetic disorder of prenatal and postnatal brain development. Children with ASD demonstrate core deficits primarily in social interactions, communication, and behavior. Impaired social interaction is one of the hallmarks of ASD. Therapeutic intervention for children with ASD is a specialized area involving professionals with advanced training. Although there is no cure for ASD, numerous therapies have been used. The most promising results have been achieved through highly structured and intensive behavior modification programs. In general, the objective in treatment is to provide positive reinforcement, increase social awareness of others, teach verbal communication skills, and decrease unacceptable behavior. Providing a structured routine for the child to follow is a key in the management of ASD. Okay, moving into chapter 19, family-centered care of the child during illness and hospitalization. Children are particularly vulnerable to the stressors of illness and hospitalization. Stress represents a change from the usual state of health and routine, and children possess limited coping mechanisms for dealing with this stress. The major stress from middle infancy throughout preschool years, especially for children 6 to 30 months, is separation anxiety. The 3 phases of separation anxiety are protest, despair, and detachment, also called denial. One of the factors influencing the amount of stress imposed by hospitalization is the amount of control that persons perceive themselves as having. Feelings of loss of control are caused by unfamiliar environmental stimuli, physical restriction, altered routine, and dependency. Because of their separation from significant people in their lives, children who are hospitalized may lack the opportunity to form new attachments in the strange environment of the hospital and exhibit negative behaviors after discharge. Common responses include regression, separation anxiety, apathy, fears, and sleeping disturbances, especially for children younger than 7 years old. Nursing care of the child in the hospital is aimed at preventing or minimizing separation, decreasing loss of control, minimizing fear of bodily injury, using play or expressive activities to lessen stress, and maximizing the potential benefits of hospitalization. Children and families require individual care to minimize the potential negative effects of hospitalization. The nurse can maximize potential benefits of the hospitalization by fostering parent-child relations, providing educational opportunities, promoting self-mastery, and encouraging socialization. Family reactions to hospitalization are influenced by many things, including the seriousness of the illness, experience with illness or hospitalization, experience with diagnostic or therapeutic procedures, available support system, personal ego strengths, coping abilities, presence of additional stressors, culture and religious beliefs, and family communication patterns. Hospitalizations have deleterious effects on siblings. Factors that contribute to these negative effects can include fear of contracting illness, their younger age, a close relationship with the ill sibling, substitute child care, minimal explanation of illness, and perceived changes in parenting. Nursing care of the family involves listening to parents, verbal and nonverbal messages, providing clergy support, accepting culture, socioeconomic, and ethnic values, giving information to families and siblings, and preparing for discharge and home care. A primary nursing goal is to prevent separation, particularly in children younger than 5 years of age. Changes in hospitals' policies over recent years reflect a change in attitude towards parents. Many hospitals have developed a system of family-centered care. They no longer consider parents visitors and welcome their presence at all times throughout the child's hospitalization. Parents may display different needs regarding involvement in their child's care. Not all parents feel comfortable assuming responsibility, and they may be under such great emotional stress that they need a temporary reprieve from caregiving activities. Others may feel insecure in participating in specialized care. On the other hand, some parents may wish to control their child's care and be involved in every way possible. Individual assessment of each parent's preferred involvement is necessary to prevent the effects of separation while supporting parents' needs. The dependent role of being hospitalized imposes feelings of loss on older children. Principal interventions should focus on respect for individuality and the opportunity for decision-making. Although these sound simple, the efficacy depends on the nurse, who is flexible and tolerant. It is also important to empower the patient and not be threatened by a sense of lessened control. A primary goal of nursing care for the child who is hospitalized is to minimize threats to the child's development. Many strategies minimizing separation have been discussed and may be all that the short-term patient requires. However, children who experience prolonged or repeated hospitalization are at greater risk for the developmental delay or regression. The nurse who provides opportunities for the child to participate in developmentally appropriate activities further normalizes the child's environment and helps reduce interference with the child's ongoing development. Play is one of the most important aspects of a child's life and one of the most effective tools for managing stress. Play and other expressive activities provide some of the best opportunities for encouraging emotional expression, including the safe release of anger and hostility. Non-direct play that allows children freedom for expression can be tremendously therapeutic. Although hospitalization generally represents a stressful time for children and families, it also represents an opportunity for facilitating positive change with the child and among family members. For some families, the stress of a child's illness, hospitalization, or both can lead to strengthening of family coping behaviors and the emergence of new coping strategies. Although preparation for hospitalization is a common practice, no universal standard or program is advocated in both general and children's hospitals. Some hospital admission programs focus on group preparation before actual admission, whereas others prepare each child either before or on the day of admission. The preparation process may include tours, puppet shows, or therapeutic play with toy or real medical equipment. Admission to an outpatient setting, emergency department, isolation room, or intensive care unit requires additional intervention strategies to meet the child and family's needs. One of the most traumatic hospital experiences for the child and parents is an emergency admission. A sudden illness or injury leaves little time for preparation and explanation. Sometimes the emergency admission is compounded by admission to an intensive care unit or the need for immediate surgery. Admission to an ICU can be traumatic for both the child and parents. The nature and severity of the illness, the circumstances surrounding the admission, and the highly technologic, unfamiliar environment are major factors, especially for parents. Parents experience significantly more stress when the admission is unexpected rather than expected. Most hospitalizations necessitate some type of discharge planning. Often this involves education for the family, for continued care, and follow-up in the home. Depending on the diagnosis, this may be relatively simple or complex. Okay, so finally we have chapter 20, Pediatric Variations of Nursing Interventions. So informed consent is valid when the person is capable of giving consent, is over the age of majority and is competent, is supplied with information needed to make an intelligent decision, and acts voluntarily when exercising freedom of choice. Informed consent is needed for major surgery, minor surgery, and diagnostic tests and medical treatments with an element of risk. Parental refusal to give consent for life-saving treatment or to prevent serious harm can occur and requires notification to Child Protective Services to render emergency treatment. Evaluation for child abuse or neglect can occur without parental consent and without notification to the state before evaluation in most states. Preparing children for procedures is beneficial in many ways. Preparation decreases their anxiety, promotes their cooperation, supports their coping skills, and may teach them new ones, and facilitate a feeling of mastery in experiencing a potentially stressful event. The major principles in psychological preparation of the child for procedures are to establish trust, provide support, and give an explanation in easy-to-understand terms. Preparation for procedures should be based on developmental characteristics of the child and family, emphasizing the importance of the parent's role. The nurse who has spent time with and established a positive relationship with the child will usually find it easier to gain cooperation. Age-appropriate explanations are one of the most widely used interventions for reducing anxiety in children undergoing procedures. The exact timing of the preparation for a procedure varies with the child's age and the type of procedure. No exact guidelines govern timing, but in general, the younger the child, the closer the explanation should be to the actual procedure to prevent undue fantasizing and worrying. With complex procedures, more time may be needed for assimilation of information, especially with older children. Most parents and children want to be together during stressful procedures and should be offered this opportunity with guidance on how the parent can comfort the child. In performing a procedure, the nurse should expect success, involve the child in the procedure when possible, provide distraction, and allow for expression of feelings. It is best to approach the child as though cooperation is expected. Children sense anxiety and uncertainty in an adult and respond by striking out or actively resisting. In giving post-procedural support, encourage children to express their feelings and praise them for completion of the procedure. Nurses assess compliance with treatment by measuring factors that affect compliance through clinical judgment, self-reporting, direct observation, monitoring of appointments and therapeutic response, pill counts, and chemical say. And this is the reference. Okay. Oh. Looks like a slide got out of place. So an elevated temperature, most frequently from fever, but occasionally caused by hypothermia, is one of the most common symptoms of illness in child. The principal reason for treating fever is relief of discomfort. Relief measures include pharmacological or environmental interventions. The most effective intervention is the use of antipyretics to lower the set point. Ensuring safety in the hospital setting is a major concern and can be achieved through environmental measures, limit setting, infection control, and safe transportation. Fall preventions begin with identifying children at risk of falling by performing a fall risk assessment for patients at the time of admission and throughout hospitalization. According to the Center for Disease Control and Prevention, approximately 2 million patients each year develop nosocomial or hospital-acquired infections. These infections occur when there is interaction among patients, healthcare personnel, equipment, and bacteria. Nosocomial infections are preventable if caregivers practice meticulous cleaning and disposal techniques. Restraints are used cautiously and require medical order. The use of mechanical support such as immobilizers for fractures, orthopedic devices to maintain proper body alignment, leg braces, protective helmets, and surgical dressings are not considered restraints. Nurses must have an understanding of the safe dosage of medication they administer to children, as well as the expected action, possible side effects, and signs of toxicity. Factors that affect drug dosage determination are growth and maturation, difficulty in evaluating a drug response, and body surface area. Family teaching regarding medication administration includes informing parents about why the child is receiving the drug, its possible effects, and the amount, frequency, and length of time the drug is to be administered. Okay, now that is all I have for you guys today. If there are any questions, I'll be on for another half hour.
You are currently the only person in this conference.
Hello, Christine.
Hi, how can I help you?
Hi. I just have a question. We just took our first pediatric exam, and I'm pretty sure I did terrible.
Oh, did you guys get your grades back yet or not yet?
Not yet, but I just don't feel confident. I don't know what else I could do to study because I read the book, all the PowerPoints. It's just I don't know what else to do.
Did you do the questions and case studies that coincide with the chapters on the Evolve website?
I also practiced the evolve questions as well.
Okay, did you do the case studies?
Not all of them, but
Okay, so I would definitely suggest taking advantage of all the case studies. Most of the students I've tutored in the past that didn't do great in pediatrics and then repeated it, the biggest thing they changed was really taking advantage of the Evolve resources the second time around, and most of them the second time around get A's, and that's what they attribute to their success doing it again. So definitely take advantage of those practice questions as well as the case studies. And who knows, you may have done better than you think you did. I always thought I didn't do well on exams and then was surprised to see that it was okay.
Okay. Yeah, I'll probably check that out then. She's did you have Professor Rollins or?
No, I took pediatrics with Professor Seaman. Nikki, or Dominique, who does the other peds, she took it with, I believe, Dr. Rollins.
Ah, okay, okay. Yeah, her questions were I don't know, it's just I guess I was caught off guard. It was just a tricky exam.
Yeah, in level 3, you start doing a lot more of the kind of application questions and less of the like spitting out general knowledge questions.
Mhm.
So those can be kind of difficult to adjust to at first. When you do the practice questions, even if you get them right, do you read the explanation for why you got it correct?
Yeah, the rationale. Just
Yeah, definitely like really read and study those rationales too.
Okay. Yeah, I don't really have any questions. I just wanted to talk to you if you had any more like tips. I don't really have questions.
That's fine. I'm here for that too.
Okay, thank you.
You're welcome. If you need anything else, just let me know.
Thank you.
You're welcome.
You are currently the only person in this conference.